And we're also going to be talking about treatments and why we choose certain drugs for certain rhythms, and why why those same drugs for other rhythms are, potentially life-threatening. But in order to kind of get a good start on this, we got to kind of start with the beginning, and we've got to look at where the electricity comes from in the heart. So to do that is a very complicated explanation of how the sodium potassium pump works and produces the automaticity of the myocytes. So how does the heart produce its own electricity? And the answer is the sodium potassium pump. However, it's kind of complicated, but there is a wonderful video from the Khan Academy on YouTube. If you guys have never seen this, it's very good. And we are going to watch it's about a 12-minute video, and he goes through and does a really good job of explaining how the sodium potassium pump works. So we're going to watch that to start with, and then we're going to get into the presentation. So can everyone see the video?
Overlapping is really what
How's
we call
that?
squeezing. So this is a squeeze
There we go.
version of the cell.
Perfect.
The first one was a relaxed version. And the trigger that kind of gets it from squeezing, and then of course, actually I should probably draw that too. The fact that of course at some point it has to go back to relax to do it again, to beat again. But the trigger for squeezing is calcium. So it's easy to get confused when you're thinking about all this kind of squeezing, relaxing, all this kind of stuff. But if you just keep your eye on calcium and think about the fact that calcium is the trigger, then you'll never get confused. You'll always be able to kind of find your way in terms of where the heart is in its cycle. So I'm going to draw for you the heart cycle, specifically the cycle of an individual cell. This is what one cell is going to kind of go through over time. And the heart cycle, or the cycle for a cell, a heart cell, is going to be measured in millivolts. We're going to use millivolts to think about this, and you could use, I guess, a lot of different things, but this is probably one of the simplest things to kind of summarize what's happening with all of the different ions that are moving back and forth across that cell. Now, the major ions, the ones that are going to mostly influence our heart cell, are going to be calcium, sodium, and potassium. So I'll put those three on here. And I'm putting them really just as benchmarks, just so you can kind of keep track of where things would like to be. So calcium would like to be at 123 millivolts, sodium at 67. And what that means is that if these were the only ions moving through, then sodium would like to keep things positive, and potassium, on the other hand, would like to make the membrane potential negative. So this scale is actually the scale for the membrane potential. And if we move up the scale, if we go from negative to something positive, this process would be called depolarization. Depolarization. That just means going from some negative number up towards something positive. And if you're to do the reverse, if you're going to go from something positive to something negative, you'd call that repolarization. Repolarization. So these are just a couple of terms I wanted to make sure that we're familiar with, because we're going to be able to then get at some of the interesting things that happen. I'm going to make some space here inside of this cell. So let's start with a little picture of the cell. So let's say that this is our cell here. And I'm going to draw in little gap junctions, which are little connections between cells. So maybe a couple there, maybe one there, maybe one over here. And let me label that. So these are the gap junctions. Gap junctions. And also, let's draw in some channels. So we have, let's say, a potassium channel right here. And we know that potassium likes to leave cells. So this is going to be the way that potassium is going to flow. And it's going to leave behind a negative membrane potential, right? And let's say potassium is the main ion for this cell, which it is. Then our membrane potential is going to be really, really negative. In fact, if it was the only ion, it would be negative 92, but it's not. It's actually just the dominant ion. So it's over here, and our membrane potential is around negative 90. And it continues around negative 90, so let's say nothing changes over a bit of time, so we stay at negative 90. So this is what things look like, right? With the dominant ion that our cell is permeable to being potassium. Now, a neighboring cell, let's say now, has a little bit of a depolarization, so it goes positive. And through the gap junctions leaks a little bit of sodium and some calcium. So this stuff starts leaking through the gap junctions, right? Now, what will happen to our membrane potential? Well, it was negative 90, but now that we've got some positive ions sitting inside of our cell becomes a little bit more positive, right? So it goes up to, let's say, here. And it happens pretty quickly. So now it's at negative 70, up from negative 90. So at this point, you actually get, I'm going to erase gap junctions, but now that you're at negative 70, you actually get new channels opening up. And I haven't drawn them yet, and I'm going to erase sodium and calcium just to make some space. But you get new channels opening up, and these are going to be the sodium channels. So let me draw those in. Sodium channels, and there's so many of them. Lots and lots of these fast sodium channels open up. And I say fast because the sodium can flow through very quickly. So sodium starts gushing in, and you know that's going to happen because there's a lot more sodium on the outside of a cell than the inside of a cell. And so sodium gushes in, and it's going to drive the membrane potential very quickly up to a very positive range. Now it would go all the way, let's say, close to 67, maybe not exactly 67 because you still have those potassium ions leaving, but close to it, if not for the fact that these voltage-gated channels actually close down. So these sodium channels are voltage-gated, and they will actually close down just as quickly as they opened up. To show that, I'm actually going to do a little cut paste. I'm going to just draw this cell here, and I'm going to move it down here. So we've got our cell just as before, and now these voltage-gated channels, they close down. So let me get rid of all these arrowheads. But we're already now in positive range. So at this point you could say our channels have caused a depolarization. And let me just quickly show these shut down so you don't get confused. There's no more sodium flowing through. You still have some potassium leaking out, but that's kind of as it's always been. And in addition to those potassium channels, that little channel I've drawn here, you have new potassium channels that open up down here. And these are actually voltage-gated potassium channels. So you had them before, they existed, but they were actually not open. So let me just draw little X's. And the only reason they flipped open is because the depolarization happened. You had a negative go to a positive. So now that our cell is in positive territory, actually let me write in positive 20 or so, our potassium voltage-gated channels open up. So these voltage-gated channels open up, and you can guess what's going to happen. Like, which direction do you think that the membrane potential will go? Well, if the sodium channels aren't gushing the sodium inwards and potassium is leaking outwards, now you're going to have a downward depolarization, or repolarization. So now potassium is causing the membrane potential to go back down, and let's say it gets to about positive 5. And if it continued, again, it would go all the way back down to negative 90, but an interesting new development occurs. At this point, I'm going to actually cut paste again, and I'll show you what happens next, which is that calcium. This is the thing I said, keep your eye on the whole time, right? Calcium finally kind of starts leaking in. So let me get rid of this. And this is the key idea, right? So we still have, I don't want you to forget that this is potassium, so you still have potassium, and that's the same over here. But now calcium leaks in, and let's draw that over here. So you have these calcium voltage-gated channels that allow calcium to come in. So you've got calcium coming in, potassium leaving. Now think about what will happen in this situation. So calcium is going to want to rise the membrane potential this way. Potassium leaving is going to want it to continue going down this way. And because both are happening simultaneously, you basically get something like this. You get kind of a flat line. So because both events are happening, both potassium leaving the cell and calcium entering the cell, you get this kind of flat line. And the membrane potential stays kind of around the same. And so we can just write something similar, something like positive 5. Just so we're clear, these are also voltage-gated calcium channels. So to round this out, then what happens after that? So you have, so far so good, we have all these cells, or all these channels coming in. to our cell and allowing different ions passage. And now we get to something like this, and I'm going to try to clean this up a little bit. And what happens is that the calcium channels actually close just as suddenly as they opened. So now you don't have any more calcium coming in. And if calcium was the only thing that was keeping this membrane potential going flat, I said that the potassium makes it want to go down, but the calcium was making it flat. Well, what will happen now? Well, if again you have just those potassium channels open, well then you're going to have the membrane potential go back down. It's going to go back down to -90 or so. So this is kind of the last stage where those potassium channels are going back down, and those voltage-gated potassium channels also close at this point. So finally they close down as well. And so now that they're closed, you're going to finally get back to just your initial state, which was having a little bit of potassium kind of leaking out of the cell. And those voltage-gated channels have shut down now. So now that you're at -90, you stay down there, and this process is ready to begin again. The last thing I want to say is the stages, how they're named. So this is stage 4, this kind of baseline negative state that the relaxed muscle cell is in. And then this action potential, when it finally fires and it hits that -70, this is actually considered a threshold. This is our threshold. When it gets to that point, we call that stage 0. And then on the other side of stage 0, you have stage 1, 2, and 3. So stage 1 is that point when just the potassium channels first open up, the voltage-gated ones. And then stage 2 is when they're balanced with the calcium channels. And stage 3 is again when you have just potassium channels, voltage-gated ones that are open. And then you get back to stage 4 again. So this would be stage 4. And because stage 0 is happening so rapidly, because this is so fast, we actually call this a fast action potential. So compare that to how the action potential goes in the pacemaker cells, where it's much slower. This fast action potential is a result of those really, really amazingly quick voltage-gated sodium channels.
All right. Any questions on that?
So we're going to talk about pacemaker cells, and these are actually...
Okay. Which screen are you guys looking at right now?
You're on like a YouTube.
Yeah. Okay, so let me just there. Are you guys seeing the slideshow now?
Yeah.
It's not the presenter view, it's the actual slideshow.
No, it's presenter view.
Yeah, it's just the slideshow, not the presentation.
It's just the presentation? Okay, good.
It's all right. The presenter view, Joe.
It is? What the heck? It's not the one I clicked on. All right, well. Okay, I guess we'll just do it from this then. Hopefully I can remember what my notes were. All right, so let's get started. So we talked about you heard from the guy talking about the action potential and how the actual sodium potassium, that's how the electricity is created inside the cells. This is how the heart begins pumping. This is how it works. This is what the EKG picks up. These are what the lines basically mean, and part of it. We have a certain starting with the SA node. We've all seen these. We all know our proper intrinsic pacing cells. So our SA node is 60 to 100. Atrial cells typically are 55 to 60. The AV node 40 to 50. We all understand that heart rate's based on where that can start. So understanding the electrical flow, I had to go back to beginning of medic school to remember this stuff, but we have Eindhoven's triangle. Dr. Eindhoven was basically the creator, inventor of electrocardiograms. He's the one that developed this whole process of lead 1, lead 2, lead 3, and cardiac monitoring. And he does it through this triangle. So your right arm mostly plays the negative lead, with your left arm and your left leg playing positive leads. Your left arm does play a negative lead in when you're looking at lead 3. And it's basically just the way it reads. You can see in the triangle there, it shows the electrical flow of how it's reading. So when you're looking at lead 1, you're looking at the electrical flow from the right arm to the left arm. If you're looking at lead 2, you're looking at a picture from the right arm down through the heart to the left leg, to that midsection. And then lead 3 is left arm to the left leg. So it's basically just picking up on the electrical patterns. And that's why we see, and it brings it into the axis of your axis deviation. Your normal axis deviation, it shows there, it's about negative 30 degrees to about 100 degrees positive. That's the normal axis. That means on leads 1, 2, and 3, we should see 3 upright QRS complexes. The three peaks should all be showing positive. And that's just the way that's just showing the electrical flow through the heart and is functioning properly, and that the leads are picking up properly. When you start having injuries like MIs, and you start having injury patterns to the electrical pathways, you start seeing disruptions to that flow of electricity. You might see, left axis deviation. So you might see it kind of start tipping up towards that negative 90, negative 60 area. Or you can go to like an extreme right with like ventricular tachycardias and end up over in like the negative 150s. And that will change the way the electricity is picked up by the EKG. And that's where you see, you'll see negative deflections of the QRS complexes. You see your bundle branch blocks, which we'll talk about later. You start to see those patterns emerging. So let's break down one QRS complex, or one heartbeat. So the P wave is the first thing that we're always looking for. P wave tells us that the heartbeat is coming from the SA node, from the sinoatrial node. It's the depolarization of the atria. That's what it shows. So the atria has triggered. You'll have a little bit of pause, which we call the PR interval. And it's basically what that is it's the AV node holds that electrical signal for just a few milliseconds. So basically, it's the fill time. Think of it as the fill time from the atria to the ventricle. It allows the ventricles to fill. Once that time is processed, the signal is sent from the AV node down to the ventricles along the Purkinje fibers, bundle of His, and that triggers the ventricles. The QRS complex is the depolarization of the ventricles. It's the main pumping contraction. The ST segment is another slight resting period. It's where the ventricles repolarize, so everything's kind of coming back. It should be nice and flat. It should be even with the PR interval. So if you draw a line from where that ST segment arrow is, actually, isn't there a pointer, right? So you should be able to draw a line from here. This should all be even. This whole line right through here should be nice and even and flat across. Your T wave is the repolarization of the ventricle. So it's the ventricle getting ready to fire again. The T wave typically should be slightly asymmetrical. It should not be peaked. It should kind of have this nice little asymmetrical kind of foothill, if you think about it. Kind of like some of the mountains around here. It's more of like a foothill. Should not be tall or anything like that. Can you draw on this thing? So it should not look like that. Can you see that? I've never used this stuff before.
Yeah, Joe, we can see that.
Okay, cool. I've never actually used any of these tools on PowerPoint before. So that's kind of cool. All right. Any questions on that? On what we're actually looking at with a QRS with an actual QRS complex? All right. So, what are we looking for? When a 12 lead prints out or a rhythm strip prints out, what are the medics? What are the docs? What are we looking at? Well, we're looking to see if the rhythm is regular. We're looking to see what the heart rate is, which is usually given to us in a number, but there's a few other kind of ways you can like jerry kind of get a number, jerry rig a number. It's not the most accurate, but it gives you gives you a ballpark of where the heart rate is if it happens to not print the numbers. Are there P waves? What's the PR interval? What's the QRS duration? QRS duration gets important when we start talking about bundle branch blocks, ventricular tachycardias. It can also be present with. It can elongate with like tricyclic antidepressants, overdoses with TCAs, cocaine can all cause issues with the QRS duration. Your T wave. T wave is a very good indicator of electrolyte imbalances. So patients that might have hypernatremia, so high sodium, high potassium, or hyperkalemia, and even like hypocalcemia or hypercalcemia. So T waves really give us a really good in kind of look at how our electrolytes are doing. Ectopic beats. So those are like, you get a normal sign. If there's like just a regular normal rhythm and a PVC fires, that would be what we would consider an ectopic beat. It's just an out of place beat. Not necessarily, it could be a PAC or a PJC, which we'll talk about a little bit about later. They're random escape beats that sometimes the heart fires. You get a cell that's a little extra excited and can't hold himself back. And looking at P waves, looking at the QRS duration, looking at all of this stuff can tell us the origin of that rhythm. Did it start in the SA node? Did it start in the AV node? Is it somewhere else in the atria? Or are we dealing with a total disassociation between our atriums and our ventricles? So, interval measurements. Now we're going to kind of take that first slide and we're going to jump into a little bit more of kind of in-depth and stuff. So we talked about the P wave and the PR interval, and that is the P wave is the atria firing, with the interval being the resting state while the AV node holds on to that electrical charge. The Q2 interval is an important thing. Whoa, I got to remember to keep doing this. So your QT interval is important. This is like your repolarization points. Certain medications can affect this. The AEMTs that are here, you guys, when you guys were taught about IV Zofran, we told you that like with patients with cardiac histories, especially if they have bundle branch blocks or have history of wide complex tachycardias, like Zofran needs to be given very slowly. Should be given 30 seconds to a minute. Well, Zofran has shown to affect the QT interval. And if you elongate this, if you make this QT interval longer and longer and longer, well, you get this space in the ST segment that gets longer and longer, and the heart's going, okay, what's going on? Okay, what's going on? And then you get many cells that fire at once, and that's what could lead to ventricular fibrillation, ventricular tachycardia. So that's why we give Zofran nice and slow, is this QT interval. That should be, it says 0.4 to 0.43 seconds. If you look at like the monitor printouts, it's going to give it to you in milliseconds. So it should be 400 to 430 milliseconds. Your PR interval, backing up a little bit, should be 0.12 to 0.20 or 120 to 200 milliseconds. And your QRS duration should be 80 to 100. It actually should be should be 0.12, 0.08 to 0.12. So when we're looking at for ST elevation, that's the big thing. When we look at a 12 lead, what are we looking for? What's the big thing we're looking for? ST elevation, right? ST elevation, ST depression. So we measure from the J point. The J point is the end of the S wave, the beginning of the ST segment. So it's basically when you see the S wave, when the S wave starts to make its upslope here, it's the first, I'm sorry, I don't have a very straight hand here. It's the first deviation of the S wave to come flat. So sometimes it's a nice sharp point like it's showing here. Other times it can be a bit more rounded of a point. So it might come in and it might round off here. So the J point is when it starts to make the turn from the upslope. So as it comes up, as it starts to turn, that's your J point. The J point is that first change in deflection. That's what we're measuring from. If that J point is greater than 1 millimeter above the isoelectric line, that's what signifies ST elevation. And vice versa, if the J point is down here, you end up with 1 millimeter of depression, which is like an ischemic change. Doesn't necessarily mean they're having an MI, but it could mean that they're on their way to having an MI. Pardon me, just grab a drink of water here. And then, like I said, your T wave, you go on to the T wave. T wave should be nice, usually mostly asymmetrical. It can be symmetrical at times, as long as it's not like really peaked high. It's usually fine, as long as it's not peaked really high or flat. That's when it gets worrisome. Any questions so far? Please don't hesitate to ask them. Write them in chat, or unmute yourself and just ask them. Giving people a second, seeing none. All right. So I said that there's other ways to kind of count your rate, instead of like if you're unable to for some reason it doesn't print a number for you. So what you can do is you can take a 30-second strip, or a 6-second strip, excuse me. 6-second strip is 30 of these bigger boxes that you see on here. So 30 of these boxes signifies 60 seconds or 30 seconds. No, 30 of the boxes signifies 6 seconds. You count the number of QRS complexes in this 6-second strip. You multiply that number by 10. That gives you a rough estimate of 70 beats per minute. It's not exact, but it gives you a fairly good idea of the number of beats per minute. The other way you can do it is you find a QRS complex that has the T wave, the peak of the R wave here starts on the big thick line. And then you count over. The first big thick line from there is 300, and that's 150, 100, 75, 60, 50, 40, 30, and you get the idea. Again, this is a rough estimate. It's not exact. It's just a rough estimate where if you, like I said, if you didn't have the printed number, you could do that. Oops, wrong button. All right. So what's normal? Well, this is a normal EKG. It's a typical like regular 12 lead. There's nothing wrong. There's nothing here that's jumping out at us. I figure we should probably look at what's normal before we jump into what's not normal. So you can see we have our 12 leads here. You can see, and you get a longer strip of lead 2 at the bottom. So when you look at this, every medic has a slightly different way of looking at it. I kind of personally now look at V1 first. I look for my width. The numbers that are given. So when you, the top of like the LifePak 12, you'll see like the QRS duration will say like 0.13. I need that. Well, we need that board that guy has. you'll see like 0.12. So this gives you the duration of the QRS complex. So I'm looking at this stuff first, making sure that there's no width there, that we're not dealing with like a right bundle branch or a left bundle branch block, trying to rule that stuff out first. Because once somebody has a left bundle branch block, it makes certain other things hard to look at. So eliminating that right off the bat is the best. And then you go through and you're looking at, okay, what kind of rhythm are there P waves? Okay, I got P, and you only have to look at one lead really for this. Okay, there's a P wave there, P wave there, P wave there. They've got QRS complexes with all of them. Okay, so it's a sinus rhythm. Everything else looks good. ST segment is nice and flat. It's nice and flat with the isoelectric line. And you're looking at this in patterns. So we all know our inferior leads, I think. So you have these guys for your inferior. So you look at these guys as a group. And then you're looking at, then you can look at lead 1 and AVL as a group. Wish I could change colors. I don't know if I can. And then 5 and 6 also go along. V5, V6 also go along with 1 and AVL. So you have your inferior leads here. And you have lateral here. V3, V4 are they're a group amongst themselves. These are the anterior leads. Now there's some docs now are saying that it used to be V1 and V2 were what we called septal. Septal is a very small section of the heart. So a lot of docs now are starting to basically lump V1, V2, V3, and V4 as they're just all anterior leads. If 2 and 3 are elevated, it's an anterior MI. So that's kind of like that's what we're looking at when we're looking at just something normal. This is kind of the pattern we're looking at. We're looking at the duration of the QRS complex. We're looking at the PR interval. We're looking to see if the P waves match with the QRSs, and then we're looking for our ST elevation, and we're looking in these specific patterns. So we're looking at the inferior leads. We're looking at the lateral leads. We're looking at them in groups. To diagnose an MI, you have to have 2 contiguous leads. So that means you have to have 1 in AVL, or AVL in V5, or 5 and 6, or 2, 3 AVF, 1 and 2. 2 of those have to be elevated more than 1 millimeter in the ST segment. Any questions? Am I going too fast? Speak up. Garrett, do you have anything to add to any of this?
Yeah. The only thing I say, the kind of the most important thing we do, because it can be overwhelming when we're taking into account a 12 lead. Just so everybody knows, step 1 that we do is we identify our rhythm before we even jump to trying to figure out, is it a STEMI? Is there a bundle branch block? Is there peak T waves, all that stuff. The number 1, especially those who are going through medic school, you need to identify your rhythm. Is it a normal sinus? Is it regular, irregular? All that kind of stuff. If you can't identify your rhythm, then, the rest is going to come later, but you really need to identify your rhythm first. And same with you, Joe. I use lead 1's kind of I jump to first.
Yeah, well, I mean, I've going through my flight bridge stuff, like Eric Bauer brings up a really good point with the whole, I look at V1 first and I look at the QRS duration, because if you have a left bundle branch block, a lot of other stuff is thrown out the window. You've got to jump down a bunch. So ruling out left or right bundle branch blocks, you can do that in 2 seconds before you look at the rhythm. Is it wide?
Exactly.
Nope. Okay, I don't have a bundle branch block. Okay, go on to what do I have for rhythm? Do I have ST elevation? That's the way I personally do it. But and those of you that are going to medic school, Garrett's right. You're going to be taught identify your rhythm first, identify your ST elevations, and that you're going to be taught that process, and that's okay. And you'll eventually learn your own process of doing things. We're all slightly different. Garrett looks at 12 leads a little different than I do. Stryker looks at them a lot different than Garrett does. So and doctors look at them completely different also. So
Right, exactly.
You develop your own style, I guess is the best way to put it. Now, I don't know if I click next. Oh, it is display. Okay, cool. All right, so with that being said, we've looked at normal. So let's start looking at where rhythms come from. And we're going to start with that, the originating or rhythms in the SA node. There's really 5 of them, basically. That's your normal sinus rhythm, or sinus tachycardia, sinus bradycardia, sinus arrhythmias, and sinus arrests or escapes, they call it. And so normal sinus, obviously, it's normal. SA node fires, the rest of the heart follows. You have a nice, normal EKG. Sinus tachycardia is not really one that we often, it's not a treating rhythm. We don't see sinus tachycardia and go, oh, we need to treat that. Sinus tachycardia is always a byproduct of something else going on, such as sepsis, hypoxia. There's always a cause of sinus tachycardia. Sinus tachycardia is never the cause itself. And the same with bradycardia. However, bradycardia is something we treat. When the pulse drops below 60, we start having problems with mentation, low blood pressure, altered mental status, and there's all sorts of reasons why hearts become bradycardic, and it can be anything from toxicity, such as like organophosphates, to let me see if I can pull my notes up here. I apologize. Kindle doesn't make it as easy. This is why I wish it was. Sorry, guys. Just bear with me for 1 second here. So yeah, so there's so many issues that cause sinus bradycardia. It can actually be a sleep apnea issue too. So sleep apnea can cause it. Increased vagal tones. It can be from athletes, or we all know the little old lady that tries to go poop and can't and passes out on the toilet. That can cause sinus bradycardia. Typically is something that fixes itself without intervention, but it still causes the bradycardia. It causes the drop in blood pressure, and that's why we get to pass out. Inferior MIs can cause sinus bradycardia. Hypothyroidism, hypothermia. Here's a question, if anybody knows. Garrett, you can't answer this one. Can you give atropine to a bradycardic hypothermic patient?
I'm going to say no.
No.
Good. That's right. So when a heart is hypothermic and bradycardic at the same time, you don't want to go speeding it up with you don't want to be pushing the parasympathetic system down and allowing that sympathetic. You can actually cause tachycardias. You can also cause MIs, and you can cause cardiac arrest also from overstimulating the heart. So yes, if hypothermic bradycardic patients do not get atropine, they get warmed up first. They have to be. Do you remember what the temperature was for atropine? Is it 93?
I think it's 90.
90, yeah.
Yep.
Above 90, before they can get atropine.
And that's when we're working codes as well. If you're giving epi 1 to 10,000, your interval for giving the epi doubles.
Yes, correct. Yeah, so it's a 10-minute interval instead of a 5-minute interval. So you can have hyperkalemia. These are just non-pharmacological issues too. So hyperkalemia can cause it. High magnesium, brainstem herniation. So you get Cushing's reflex or Cushing's triad. Will cause bradycardia in the late stages. And then some pharmacological causes of bradycardia are beta blockers. calcium channel blockers. We see those quite a bit. Our low pressure metoprolol, diltiazem, they're all blockers. They all affect the rate. They all keep the rates down just naturally. But if you take too much of it, it can cause severe bradycardia. So sinus bradycardia, and then we have sinus arrhythmia. Arrhythmia can be caused by a breathing pattern. Can also be a diseased SA node, and it's basically it looks like AFib on the monitor, but there's a discernible P wave with every QRS complex. That's the best way to describe. To me, that's the best way to describe a sinus arrhythmia. It's regular, and then you have a small period of irregularness, and that's basically just because there's a slight pause between the next firing of the P wave. You also might see like different shaped P waves with it. So, and then a sinus arrest escape is basically just the node fails to fire. Another kind of a group of those we call it sick sinus syndrome. It's a group of rhythm that basically is caused by issues with the SA node. It's our bradycardias, can be tachycardias, can be atrial pacemaker problems, and it can just be rhythms that alternate between fast, slow, or tachybrady syndrome, which could be like your atrial fibrillations. They're often caused by electrical pathway damage. People that are older than 50, heart surgery in children can cause it. CAD, hypertension, valve diseases can all cause like a sick sinus syndrome. So that's where you get the bradycardias. I took those ones out. So you get the bradycardias, you get the sinus arrest, you might get the sinus arrhythmia. The sinus arrests are not. The longest one I've ever seen is about 7 seconds, which is worrisome, but they're typically not associated with symptoms. I've never met a symptomatic patient that's been having small sinus arrest pauses. No, it's definitely a reason to be checked out by a cardiologist because there's obviously something going on internally, but it's not really anything that we're going to take care of in the field. Did I? Okay, I did. Okay. All right. So what are we treating when we treat sinus bradycardia? So the biggest thing is treating underlying causes. Okay. So sinus bradycardia that's caused from a beta blocker overdose. Atropine's probably not going to do anything. We're not going to be able to give enough atropine to overcome that beta blocker. We use glucagon, which is actually which is like the antidote, for best choice of words there for the beta blocker overdose, but it requires a lot. It requires like 2 milligrams every 5 minutes until the bradycardia starts to relax or starts to improve. So typically we try to treat the underlying causes if we know that. Other than that, we treat the rate first. With rate problems, rate always gets treated first. So if you have a rapid heart rate and someone's complaining of chest pain, the rate gets treated first before the chest pain, because most likely the chest pain is being caused by the rate problem. We'll talk a little bit more about that when we get into supraventricular tachycardia and rhythms like that. And then once the rate's been treated, then we treat residual symptoms that might be left over. Nausea, chest pain, shortness of breath. That's when we move on to other symptoms and treat those. So atropine. Atropine's our go-to drug for bradycardia. What does it do? Well, very simply put, it's going to inhibit the parasympathetic nervous system. So it's basically going to block that vagal response. So it's going to block the body's ability to slow down. And it's going to allow for an increase in the sympathetic tone, allowing adrenaline and epinephrine to kind of get into the system and start speeding things up. Atropine is not a fix. Sometimes it requires multiple doses. The drug does wear off. So usually you got to get these patients to cardiac teams for usually implantation of a pacemaker. Sinus tachycardias, you treat the underlying cause. If they have sepsis, if sepsis is the issue that they're tachycardic, you treat that. If hypoxia is the issue, you treat the hypoxia. And then if there's any residual symptoms after that, you take care of those on the own. Like I said, sinus tachycardia is never really something we treat. We treat the underlying condition that's causing the tachycardia. Any questions? Oh, sorry. I had those slides flipped. Here's the example of a sinus arrhythmia on the left. This is the sinus arrhythmia. So you can see it's just P wave, QRS, P wave, QRS. A little bit of a gap here, and then you get your P wave, QRS. And you can see the P waves are shaped slightly different. So it's just kind of an irregular normal beat. So call it usually regularly irregular. And then your sinus arrest, you can see it goes along, and then it has a little dementia moment, forgets to fire. Looks like it probably missed 2 beats here, and then it fires on it, and then it starts firing again, and then goes off. And you may not, this may be like a one and done kind of thing, but it may happen, it may happen multiple times. Something that definitely should be checked out, but typically not associated symptomatic wise.
Just to add to that, Joe,
yeah.
Just so people know, for kids, a sinus arrhythmia is completely normal in kids, especially young children, because they're very dependent on their breathing. That's why we always say for kids, it's respiratory, and that's because their heart rate is very dependent on their respiratory drive as well. So if you see a sinus arrhythmia in kids, that's very normal.
Yep. And I'm going to actually add on to that. With kids with sinus Brady, if you see if there's sinus bradycardia with a child, it's going to be hypoxia. Kids don't just get bradycardic for no reason. It is probably 99% of the time a hypoxic issue. Hang on, guys.
While Joe's answering that phone call, does anybody have any questions on any of this stuff? Joe's doing a really good job of covering. Basically, this is stuff in paramedic school that we learned over a 3 to 6 month period. So he's doing really well covering all this in a 2-hour lesson. But if any of you guys have any questions, let me know. Now's your time to ask.
Garrett, I have a question. Can you hear me?
Yeah, go ahead.
Yeah. So I know that per protocol, we're not permitted to interpret cardiac rhythm, but how accurate is the 12 lead computer interpretation as far as when it spits out and says sinus arrhythmia or whatever, and we're looking at it and it's okay, yeah, I guess that makes sense based on the information Joe's providing tonight. Or is the computer interpretation just kind of a shot in the dark? Because I've heard it can be pretty inaccurate.
So the computer interpretation, when it comes to diagnosing the actual rhythm, it's not the greatest thing to go by.
Garrett, I know. Yep. Can you just kind of keep talking? I think.
Yep.
Hang on 1 second, guys. Derek, stand by for a phone call.
Yeah.
So to answer Derek's question there while they're talking, basically, so when we're diagnosing a person's rhythm, I go by my own diagnosis. I never go by doc in the box because it's not usually that accurate to diagnosing the actual rhythm. When it comes to diagnosing STEMIs, however, they're fairly accurate because they're able to pick up their own interpretation of if there's any sign of ST elevation. So if you ever see that come up and you have a medic available, have them take a look at it. But when it comes to diagnosing the actual rhythm, that's where they can be pretty inaccurate. Usually it comes out with abnormal finding. It doesn't say what's abnormal. It just says abnormal finding.
Garrett, I didn't hear anything you said.
That's okay. No worries. Derek just asked. So when the AEMTs or EMTs print out to 12 lead, he was asking how accurate the printout reading is. And basically what I told them was, when it comes to diagnosing the rhythm, I would say the monitor isn't the best or most reliable thing to go by. It's fairly inaccurate, especially, it's like when you show a 12 lead to 10 different medics, we're all going to come up with our own interpretation of what the 12 lead's saying. We'll all be somewhat close, but we'll all, have our own thoughts on it. But when it comes to diagnosing STEMIs, it's usually fairly accurate because it reads off of that isoelectric baseline, and then it just searches for that ST elevation in any of the leads. So I would say with STEMIs, if you see STEMI pop up on the 12 lead, I would definitely go by it. As a medic, I'm going to make my own interpretation. Is it actually a STEMI or not? Because we're also looking for other things like reciprocal changes, or is it contiguous in 2 different leads, that kind of stuff. But when it comes to diagnosing the actual rhythm, I don't rely on it at all.
Yeah. I've also so I agree 100% with you. When it comes to the numbers are very accurate. The interpretation is not always accurate, but the numbers that print out are very accurate.
Yep, definitely agreed.
Okay, cool. We'll move on. I'm going to ignore the phone from now on. So let's talk about atrial rhythms, but not SA node. So this is going to be our AFibs, our A flutters, ectopic atrial rhythms, and wandering atrial pacemakers. So we're just going to move right to the EKG. So on the left, let me bring up the little laser pointer. I'm kind of digging this thing. This is what atrial fibrillation looks like. Picture it going out longer, being very irregular. What happens is the SA node gets sick, or it starts to fail, or it gets injured in an MI, and it's not functioning properly. It stops functioning 100% properly. So what happens is the SA node doesn't fire, so some other cell's like, I'm going to play SA node, and it fires. Well, 200, and then this cell, the cell 5 over from it, decides, no, I want to play SA node. I'm going to fire. And this is what happens. You end up with nondescript P waves of all magnitudes. Like in this thing, you can probably identify, 6 or 7, 8 P waves. But in this, there's probably, 100 different P waves or cells firing so even though you're only seeing that many, there's actually probably 100 different cells that are trying to fire at this point, trying to be the SA node. And that's what causes it. Like not every one of them gets through the AV node to produce a QRS complex, but some of them get through. And that's what creates that irregular pattern. It's not always atria fires, ventricle fires. It's atria. Okay, now the ventricle will fire. Atria, ventricle fires. Atria, ventricle fires. It's very irregular. We call it an irregularly irregular rhythm. There is zero pattern, zero. You can't march this stuff out. Nothing will be the proper spacing, because these spacings should all be the exact same from tip to tip. Atrial fib will not have any of that. It will be the most irregular pattern you could think of. Atrial flutter, on the other hand, atrial flutter is actually a version of like SVT, or can be a version of SVT. The current one that you're seeing here, the telltale sign of atrial flutter is the shark fin P wave. So you can see this shark wave. Kind of looks like a shark fin. Like that's the telltale sign of atrial flutter. When atrial flutter is typically due to an accessory, you're going to hear me use this word a lot tonight, an accessory pathway. And so it's an extra pathway in the atrium that when one signal fires, it actually ends up creating multiple firings. So that's why you have you have multiple P waves. And that's why they're symmetrical. The P waves will look the same. It's not like AFib where they're all different sorts of shapes, sizes, and depths, and they're very symmetrical. They look the same. What happens is when the ventricles start to fire with the increasing atrial pathway, we start to see increasing heart rates. So atrial flutter, a lot of times you'll hear us refer to a flutter in a 2-to-1 conduction. So that means we're getting make sure I say this right, Garrett or Stryker. You're getting 2 ventricle beats for every atria fire.
Yeah, that's correct.
So if you have an intrinsic rate of 70, you have 75. If the SA node is firing at 75, if you're getting 2 ventricle beats for every one of those signals, you end up with a heart rate of 150. And that's kind of like a telltale marker of 2-to-1. A 2-to-1 conduction A flutter will always be 150 beats a minute on the dot. I've never seen anything else. Other than that, you end up, in this case, we're looking at I think this one is a 4-to-1, right? I always struggle with the thing. I think this is a 3-to-1 conduction that you're seeing here.
Yeah, that looks like a 3-to-1. Oh, part of it looks 2-to-1, but I think it's 3-to-1.
So I think I had that backwards. It's 3 atria beats to a ventricle beat, right? Did I have that back? I think I had it backwards the first time.
Yeah, it's 3 atrial beats to 1 ventricular beat.
Yeah. So had that backwards. Sorry, so the worst is when you have a 1-to-1 conduction. So every time every electrical pattern is going around circles, it is hitting that accessory pathway, it is continually activating the AV node, you end up with a heart rate of about 300. So a 1-to-1 conduction is about 300 beats per minute. It's pretty crazy fast. I've never seen it. I know it's pretty rare. 2-to-1 is the most common A flutter you will typically see. It will look a lot like SVT on the monitor. And that's why we'll end up using adenosine to slow it down. And we'll talk more about adenosine when we get to SVT. But once you slow a 2-to-1 A flutter down with adenosine, you'll start to see the underlying shark fins for the P waves. And once you see that, you know you're dealing with an A flutter, and we can change treatment modalities and use diltiazem or low pressor to start slowing that atrial contraction down. Any questions? Am I missing anything? Anything to add, Garrett, Stryker?
Nope, I think that's good.
Cool. Cool. So we're going to take a minute to talk about rhythms originating in the AV node. So this is going to be our junctional rhythms. They look normal, and for the most part, except for they don't have a P wave. So there's no discernible P wave that comes along with a junctional rhythm. Typically, sometimes you'll have an inverted P wave. Sometimes you have retrograde P wave. So that means a P wave that shows up after the QRS complex or after the T wave. You'll have P waves show up, and that's just due to the fact that if you picture the pathway map that we showed you earlier, if the signal comes from below the SA node and the electricity think of the electricity coming backwards towards the SA node. So it's coming backwards towards the limb leads. So the limb leads pick it up later versus if it was traveling a normal pathway. So you end up with retrograde, or you end up with an inverted P wave because it's picking it up in a backwards. It's picking the signal up backwards from what it should be going. So this is just your typical junctional rhythm here. You can have accelerated junctionals, which are 60 to 100 beats per minute. You can have tachycardias, which are greater than 100 beats per minute. And then you can have bradycardias, which are less than 40. Junctional rhythms there's usually causes to them. They're not usually just something that appears. Usually it's from like severe bradycardia. You get high second-degree blocks and third-degree blocks. Again, we're going to talk about those in just a minute here. Hyperkalemia can cause them, and then you can have them it can be drug-induced. Beta blockers, calcium channel blockers, digoxin or digitalis. You don't see those meds very often anymore. They're just not used. With the advent of beta blockers and calcium channel blockers, digoxin's kind of fallen by the wayside, but it used to be a medication they used to use to treat AFib. The only problem is with it is it's a very, very minimal threshold. So if this is like your threshold for digoxin, and this would be like overdose here. This would be like your OD area for it, toxicity. This is your therapeutic range. Digoxin is very small therapeutic level, and too little doesn't work and too much is bad. So they've pretty much kind of gotten away with it with seeing how there's better meds out there for it. But keep it in mind, it's not a bad idea to keep digoxin in mind. It comes from, is it foxglove? I believe it comes from the foxglove flower. Anyone want to confirm that? I might have the wrong flower.
You're correct, Joe.
Yeah, I thought so. Foxglove does grow in Vermont. Not that saying that like eating it will cause digitalis toxicity, but you know, I don't know if that's possible. If something like that could happen to like a child, if they got into it and started just eating flowers. You know, kids are weird these days with all sorts of challenges. So it's possibly something that could come up on something like that. I think it's a long shot, but I'll have to look into see if that's actually possible. But just keep that in mind that digoxin is a naturally forming medication. All right, looked at that. Okay, AV blocks. So these are you'll hear us refer to second-degree blocks. There's two types of second-degree blocks, and that is there is type 1, or the Winky Bach, or the Mobitz type 1, they'll call it. That's this one, as it's labeled. Type 2 is down. Type 2 is down here. This is just called the Mobitz type 2, or second-degree type 2. So type 1 is typically an AV node issue. So as you can see here, your PR interval starts to elongate. So this one looks normal. This one gets a little bit longer, and this one gets a little bit longer, and basically gets to the point of like, oh, hey, P wave, and the AV node just decides, you know what, I'm just going to hold on to this. I'm not going to let it go through. And you drop a beat. So you end up with this P wave all alone by itself, miserable on Valentine's Day with nobody. And then it goes back to a normal P wave. And then you start seeing the elongate, then it elongates again. And it basically just goes through this pattern. It drops one beat, and then it may drop one beat, may drop 2 beats. Then you'll see the P waves come back. Then you'll see the elongation. Type 2 down here is basically you have normal P wave. You have a normal P wave interval. So it doesn't look like there's any elongation, but you basically get drop beats. So no beat here, normal, dropped. Normal, dropped. That's the type 2. Both of these eventually lead to this one, third-degree block. This is the end stage of the first two of second-degree heart block. Third-degree heart block, or complete heart block. So basically, there is no AV node. The AV node has given up on life. It says, screw you guys, I'm done. And it doesn't let any signals through. So the atrium is firing normal. And you can see that if you march your P waves out, your P waves are going to end up perfectly in sync. So if you took calipers and measured how far apart those are, they're going to be the exact same distance apart each time. Okay, and you see that I marked this T wave. It's like, well, what are you doing there? How are you marking that T wave? What are you doing there? Why are you marking a T wave? Well, look at the T waves. See how this one looks? See how this one looks? And then you have this one. It's funky looking. It's different than these ones. The P wave's buried in this T wave. That's why there's this abnormal shape to the T wave. We call it a buried P wave, but it's there. So what's happening is the atrium's firing, but the AV node's not letting the signal go. So the ventricles are sitting there. They're sitting there twiddling their thumbs like, hey guys, I need to pump. Like, where's my signal? And you're not going to give me one? Well, then screw you guys. I'm just going to pump myself. And it shoots out its own signal and fires off the ventricles. A ventricle fired signal is never as strong as something that comes from above and works its way properly down the electrical signal. So it's a weakened pump. Because of where the electricity is coming from, because it's coming down the section of the heart, it's coming down from the Purkinje fibers. It's coming from the bundle of His. It's below the AV node. This is why we get the wide complex. You can see that it's a lot wider than the other two, than the second degree. So it's coming because it takes it longer. It takes it longer for it to spread and fire off the entire ventricle when it starts in the ventricle. It takes time for it to spread, unlike coming from a normal heartbeat. So there's no association between your atrium and your ventricles. They are doing whatever they want. The atrium's firing like it's supposed to, and the ventricle's sitting there waiting, and then it doesn't get a signal, so it fires on its own. So you get normal atrial heart rate, but you get a bradycardic ventricle rate. Most third-degree blocks, the ventricle rate will be in probably the 20s, 30s. I've had patients that have normal blood pressures with it. I've had alert-oriented ×4 patients with it. And then you'll have your patients that will be completely and utterly gort. They'll be unresponsive, or they'll be very altered with low blood pressure. And that's just due to the inadequacy of the pumping. These people need pacemakers. That's the only fix for it. All right, so we'll talk about treatments. So second-degree blocks, they can be treated with atropine if they're bradycardic and symptomatic. We try to look for any underlying causes that might be causing it. Atropine may or may not work with second-degree blocks. The studies and stuff are kind of up in the air. That some say it does, some say it doesn't. So they just basically recommend a trial of atropine before moving on. If the patient is bradycardic, if they're within a normal range, typically these patients, you treat the symptoms. If they're having chest pain, you treat the chest pain for chest pain. They're nauseous and vomiting, you treat the nausea and vomiting. We're not really worried about the heart rate if it's within if it's a normal rate. If they're bradycardic and symptomatic, that's a different case. Then we're treating it. Like I said, with atropine, we're going to look for underlying causes. And then we're also, if the atropine doesn't work and the patient continues to become symptomatic or gets worse, we're going to go to transcutaneous pacing. We're going to beat the heart ourselves. And it's not a pleasant experience for the patients. Third-degree heart block or complete heart block, I mean, it's one of those things where they teach you atropine. You should try atropine on a third-degree heart block in case it's not. If it's third-degree heart block, just pace them. Like, transcutaneous pacing is the treatment. Atropine's not going to work. There's no AV node to like help work to increase. You may use atropine, you may increase your atrial rate, you may increase your ventricle rate, but you're still going to end up in third-degree block. You're not going to bring back the AV node with atropine. The only real course for this is transcutaneous pacing. And these patients will end up down at UVM. They'll end up in surgery with a pacemaker implanted. Any questions so far on any of this? I'll take a second and give you guys a second to come up with questions. All right, seeing, huh?
For these third-degree heart block patients, I should be calling a paramedic.
I hear someone talking, but I can't hear them.
Joe, it's Derek. I just for these third-degree heart block patients, should call a paramedic then.
Yes, 100%.
Okay.
Because, like I said, I've had a lot of third-degree patients that they've been, for the most part, they've been asymptomatic. They might have a little bit of like dizziness, lightheadedness, nausea, and it seems like it's benign. Like, oh, that's not that big of a deal. The problem is these patients can take a dive quickly. So they may maintain a good blood pressure for a time, but that will end. And we don't really know when this stuff starts. So these patients can take a very quick dive. So yeah, having a medic available to start pacing is definitely the way to go.
Okay.
All right. So supraventricular tachycardia, SVT. I think everybody's favorite one except for Steve, who seems to get screwed out of being able to treat these all the time.
That's all.
So supraventricular tachycardia is a rhythm that starts in the SA node. It starts as a normal rhythm. However, there is an accessory pathway. I told you you'd hear me say this word a lot. And so what the accessory pathway is I think I actually have a picture. Yes, I have a picture on the next one here. So you see on the left here, you'll have a normal electrical pathway. So it comes down, SA node, AV node, down your bundle of his, Purkinje fibers, everything goes off. So with SVT, what happens is you get this accessory pathway that can come off. It can be here off the Purkinje fibers. It can also actually be right in here. So just below the AV node, it can actually pop back around and comes back into the AV node. It's also called the bundle of Kent. You may hear it referred to as. So what happens is kind of like with what was the one I used here a little while ago, with a flutter. So only this one's coming from the ventricle. So you have a pathway that one signal comes down, travels down, it comes back around and hits the AV node without dissipating. So you get you get one signal that continually comes all the way around and continues to fire. And then you got new signals that come down that join the club. And it's just one big old party. And that's why we start seeing heart rates of, greater than 150 typically. Usually SVT will be 150 and above. They can go all the way up to, I've seen SVTs that get as high, personally not me, but I've seen like on like medical shows, like real medical shows, not like Grey's Anatomy. These SVTs can get 230, 240, 260. They can get very fast. And just think about the quality of the pumping. Seriously? You mother... If that printed the piece of paper I tried to print 2 hours ago, I'm going to be mad. It is. Yeah. Sorry. So imagine trying to imagine how well the heart is actually pumping blood when it's going 230 times a minute. You're not getting any fill time. You're getting zero fill time with this stuff. So you end up with, again, it's kind of like third-degree heart block. Patients will maintain and compensate for a little while, but eventually the heart just can't take it anymore. And you're going to start dumping your pressure. You're going to start having altered mental status. And this will just continue until it's stopped. So you end up stopping it. Oh, I guess I got these a little out of order. We're gonna move on, and we're gonna come back to that. So with supraventricular tachycardia, that's where we're gonna use adenosine. Adenosine is for SVT. It's a wonderful drug. It works. It terminates the SVTs It binds to the AB nodes A1 receptors. It stimulates these receptors, so it depresses the myocardial effect. It's a myocardial depressant effect by decreasing the conduction, electrical impulses, and suppressing the pacemaker cell function. Yada, yada, yada. A lot of gobbledygook in there with how it inhibits the calcium influx. But basically what it does is it hyperpolarizes that cell, and it just shuts that cell off. It just shuts the cells off. And it resets itself. And that's what we're hoping with adenosine. Basically, we just shut everything down, and the heart will jump back in, the SA node will jump back in, and the hope is that that accessory pathway won't be used again. The signals will start to just dissipate where they're supposed to. That's at the end of the Purkinje fibers. If adenosine doesn't work, we have to move on to synchronized cardioversion. The synchronized cardioversion is kind of like defibrillation, only we deliver the shock at a very specific point. And we're actually have a video. We're going to watch a synchronized cardioversion here in a minute. So you'll kind of see it. They show the monitor, so you'll be able to actually see it. I'm going to back up though first, and we're going to talk about WPW, because WPW and SVT kind of go hand in hand. Okay, so Wolff-Parkinson-White syndrome, it was initially found in the late or mid 1800s, but finally diagnosed around 1930. It was finally named after the two docs that discovered it, Wolff-Parkinson-White. So what it is it's a pre-excitation of the QRS complex. So we end up with a shortened PR interval, so it ends up being less than 120 milliseconds or less than 0.12. We get this delta wave, is what it's called. And so here on the left is a normal QRS. So normal PR, QRS, well, in the case just an RS. And then over on the right here, you see the shortened PR interval, this flat section right here. And then what we get is this upslope to the QRS. This is the delta wave. This upslope here is the delta wave. This is what we're looking for. This appears typically in re-entry, but it ends up in what? It's usually in the V leads. Usually you identify it in the precordial lead. So V1 through 6, you'll identify this delta wave.
Yeah, V1.
Yeah. Stryker's here, by the way, now, guys. So you'll hear him pipe up.
and that's basically due to an accessory pathway. Wolff-Parkinson-White is always a re-entry tachycardia.
Yeah.
Now we get really fast.
Yeah. So you also get a QRS prolongation. So you get it. It ends up being greater than 110 milliseconds. You can have ST segment and T wave discordant changes. So it's basically the ST segment moves in the opposite direction to the QRS complex. So if the QRS is positive, you may have ST depression. It may go the opposite way, and vice versa. If it's a negative QRS, you might have ST elevation. However, it is not an MI. It's a conduction change with WPW. WPW can be seen without tachycardia, and I have a couple coming up. There's two types of WPW that can be identified. Yeah, isn't great? Yeah. So here on the, you know what? This is where I wish I had my notes, because
you pull it up on your.
Yeah, I'm gonna pull it. Hang on, guys, 1 second. I gotta just pull up my notes real quick. I was hoping to have my presenter view, but it didn't work. So I'm just gonna. Just gonna pull this up real quickly here so I didn't tell you guys the differences in the. All right. So the first one on the left is going to be your type A. So there's two types of patterns. There's type A pattern, type B pattern. The one on the left is the type A pattern. And so what you end up with is it's kind of the same. You have your shortened PR interval. It's a sinus rhythm. You have broad QRSs. If you look down on the bottom here, you can see that it's broad. It's also super high, but we're not diagnosing hypertrophy with these things. And so type 1 is a dominant R wave in V1. So we look at V1, which is right here, and we look at it, the dominant portion of the QRS complex is an R wave. So R wave is always the first, I should have covered this actually first at the beginning. R wave is always the first positive deflection of the QRS. So in this case, this is actually an RS wave. There's no Q wave here. So you have a dominant R wave in V1. So this makes it a type A Wolff-Parkinson-White syndrome. So what that means is that the associated accessory pathway is left-sided. So it means it's on the left side of the heart. Type 2 or type B pattern, which you see on the right here, is the opposite. So you end up with in V1, you look at V1, and you end up with a dominant S wave, which is the first downsloping wave of the QRS. So in this, you have like an actual, like you have an RS wave. So you end up with a dominant S wave. So with a dominant S wave, you end up with a right-sided accessory pathway. So with the accessory pathway is the right side of the heart. So this is what so as you can see, there's no tachycardia here. This is just a normal 12 lead that was obtained for someone that has Wolff-Parkinson-White. So this is fully diagnosable without being in tachycardia. You could get this 12 lead on anybody. In kids, it's very common in. Kids tend to get WPW, and there's one other.
A lot of times people in like their 40s usually present.
I thought I had it here, but I don't. But so yeah, So the danger with WPW is that pre-excitation and where everything happens. So when we're talking treatments for WPW, it's cardioversion only. If someone has WPW and they're having a tachycardic rate, like an SVT, cardioversion is really the only treatment. The AHA they don't recommend the use of AV nodal blocking agents such as adenosine, amiodarone, and diltiazem, which are our like 3 go-to meds for this kind of stuff. However, they do say if you have to use a medication for WPW, amiodarone is the one that they recommend to be used. I think due to it's
a lot of times because in that accessory pathway, the rest of your heart isn't getting depolarized, repolarized, and that can basically throw you into a lethal rhythm, VFib, VTAC, asystole, etc. So they don't want you slowing that down and that impulse still getting stuck in that accessory pathway going, however fast it's going to go if you're in a tachycardia.
Yeah. And amiodarone works in that phase 3 section of the heart. So it works in the duration of the action potential, and it actually it delays the repolarization and increases that duration. So you get a longer space in between the ability for the cells to depolarize. So that's how amiodarone helps to slow a heart rate down.
Tries to increase your QT interval, yeah.
Yeah. So it's a really good medication. Works very well for VTAC and things like that. But so of the 3, adenosine is a no-no with WPW. So it's one of those things where, like, when you have a patient with SVT, finding out if they have a history of Wolff-Parkinson-White syndrome is actually really important. I think sometimes it slips. We get tied up with like, oh, SVT, treat it with adenosine, and we forget that sometimes we might want to ask, hey, you ever been diagnosed with Wolff-Parkinson-White syndrome? Because it's important to know. These patients can be at increased risk for actually, no, these one. This is why I hate not having my notes. Yeah, so it's not a super deadly rhythm. There's a very small risk with sudden cardiac death with WPW, But obviously, if they're in a tachycardic rate, the longer and faster they're going, the faster you want to get them out of a fast rate. The heart will only go for so long before it tires out.
I don't want to get too technical, but if you go back to those two Wolfpack in white,
Yeah.
Do we cover our way progression or anything like that?
No, I
Probably
didn't.
not.
I didn't, just because.
I was just trying to explain why this would be right and that would be left sided, as you were saying before.
Oh, yeah. I didn't get it. I didn't get into our way of progression. I wasn't going to get that.
I don't know if we want to get that technical. Okay.
It's
Yeah.
still have quite a bit to go. So ventricular rhythms. I think everyone's familiar with ventricular tachycardia, fibrillation, idioventricular rhythms. Basically, well, I don't know where this rhythm's coming from. That's basically what idioventricular means. Idiopathic means I don't know. VFib, we all know what VFib looks like. We all know it's basically a complete and utter breakdown of the electrical system of the heart. Looks like a white man dancing on the monitor. No rhythm whatsoever. So this, obviously, we all know how to treat VTAC. We all know how to treat VFib without pulses. It's CPR and defibrillation. I'm not going to spend a lot of time on those. Torsades de Pointe, if there's a pulse associated with this, they get magnesium. Magnesium's decreases a calcium influx as well as sodium. It's also a smooth muscle relaxant, so it helps to slow the depolarization and everything of the heart down.
Sometimes you can see these in people with severe electrolyte imbalances, mainly magnesium. That's why you're giving a magnesium to try to prolongate that QT interval back to a normal baseline.
Low magnesium will cause this. All right. So let's talk about a little bit more about on 12 leads and non-typical findings for MIs. We talked about like what a normal 12 lead looks like. We talked about ST segment elevation. However, there are injury patterns out there that don't have ST elevation or ST depression associated with them, but they're still considered STEMI equivalent, what we would call a STEMI equivalent. So it's still an MI. So this is just like what we talked about earlier, just a little lead summary. Sorry for this presentation being slightly out of order with certain things, but you can just a reminder of where your certain arteries are and where they fall in those leads. So this is just a basic high lateral MI. You have leads 1 in AVL elevated. You have reciprocal changes in AVL and leads 3. So that goes along with your high lateral MI. You can tell that it's reciprocal because if you flip 3 right side up, so if you brought this and went positive, AVL and 3 would be identical. That's how you know those two are reciprocal. So this is what we're talking about, 2 contiguous leads. So 1, AVL, they're grouped together, so they're contiguous leads. They're the lateral anterior descending artery. And it's typically high up in it. So this would be the widowmaker. That high up in that artery. So let's look at some other patterns. Garrett, you know what this is? Seeing how you're the only medic here. You leave? You there?
It says Crocker and destination.
Yeah, I don't know why, but.
Sorry, Joe, I'm driving. Hold on one second.
Jeez. Don't worry about it. If you're driving, don't look. So this is what we would call, this is like a classic left bundle branch block. Wide QRS complex, greater than 0.12. It's got a funky, you can see that the line of the Q wave here is not straight. Let's see if we can find it a little bit better. You can see it a little bit better in 4. He kind of like comes down, has a little bit of an offshoot, and then goes down more. Kind of has an odd shape to it. So that would be QRQ prime, right? Something like that. But so this is the classic left bundle. Why is left bundle a big deal? Everybody makes big old big deal about left bundle branches. Like, ooh, you got a new left bundle. There used to be with left bundles, because of the way and where it is, the left side of the heart. So left bundle branch block, what it's saying is the left bundle of his, the left Purkinje fibers, that means there's a block along the electrical pathway. So it takes the electrical signal longer to go around that block and get back onto the pathway. This is why we end up with a wider QRS complex, because the time it takes for the ventricle to depolarize is longer. So it's wider. So wider is associated with longer.
Yeah, it's going to revert to cell depolarization versus going straight down the bundle branch track, which is obviously a lot faster.
Right. Why this is a big deal is the left side of the left Purkinje fibers, the left bundle of his, it is a wider group of fibers. It's a larger electrical system there. It's the left side of the heart. It's the largest part of the heart. So the chance of injury, it takes a massive injury or infarct to cause something like this to happen. So the old thing was, if someone has a new left bundle branch block, oh, well, if they have a bundle branch block, there's enough damage to the heart that they must have done. There must be some sort of blockage or acute coronary syndrome kind of thing going on. So that's why left bundles have always been kind of this new left bundles, treat them like an MI. That's why you hear the medics ask about that whenever we see left bundles. Have you ever been told that you have a left bundle branch block or a right bundle branch block? Like, we want to know. We don't have the ability to, like the hospitals, to just go to the records and look at an old EKG. Maybe someday, but right now we don't have that ability.
Yeah.
No, that's the problem. So when someone does have a left bundle branch block, how do you tell if they're actually having an MI? Well, glad you guys asked that question. So we use what's called the Scarbosa criteria. There's three criteria that you can meet. You don't have to meet all three for it to be considered positive. You have to basically get a score of 3 or equal. So basically, it's either 1 or 2 of these that you'll have. You'll see the patterns here on the right, A and B. These are what normally should show for a left bundle branch block. So you'll have a positive QRS, and you'll have a depressive ST T wave. So it's opposite of each other, discordant, so it's opposite. Same with B, you have a negative deflection QRS, you have a positive deflected ST segment and T wave. With the Scarbosa criteria, if they're concordant ST elevation, so like in A, you would have positive, this would be, oh, I keep doing,
Yeah.
can't see my hand when I do that. I forget, I talk with my hands.
Flip it upside down.
So if you flip this section upside down and made this elevated by greater than 1 millimeter, that would be a positive finding. So concordant ST elevation, or concordant ST depression, as you can see in the next one. So if they have the concordant ST elevation, they get a score of 5. If they have concordant ST depression in V1 through 3, it's a score of 3. And the concordant ST elevation can be any of the precordial leads. Excessive discordant ST elevation greater than 5 millimeters in leads with a VE QRS complex gets a score of 2. So this was developed, I think in the 50s, I think it was. No, I don't even think it was that long ago, 80s.
80s, I think.
80s.
Yeah.
This was developed in the 80s. It's a criteria that's very specific, but it wasn't actually very sensitive to myocardial infarctions. It was about 90% specific, but its sensitivity wasn't great. So another doctor in the early 2000s, I think it was, Dr. Smith, came out with the modified Scarbosa criteria, which basically the first 2 things are the same. The concordant ST elevation and the concordant ST depression. Those 2 stayed the same. What changed was the excessive discordant ST elevation, whereas it used to be greater than 5 millimeters, is now being put as defined as 25 greater or equal to 25% of the depth of the preceding S wave. So it's a little bit more complicated. So the S wave prior to it, you have to compare the ST elevation to the S wave, and if it's 25% or more of that S wave height, it would be a positive finding for the Scarbosa criteria and likely leading to an MI. If I lost anybody, it's complicated stuff, but it's interesting things with it, because bundle branch blocks are actually very common out there. We see a lot of this. We see a lot of these out there, and they can throw you for a loop, because if you got a tachycardic, you got a patient that's tachycardic with a left bundle branch block, like even at like 120, it can look like VTAC. Mm-hmm. It can. It's not, but it can look that way, and it can really throw you off. So being able to identify, with the left bundles, you'll still identify P waves. You'll still have discernible T wave, ST segments. You still have all of this stuff. Whereas with VTAC, you're not going to have any of this stuff. So new left bundle equals STEMI. Well, the AHA, or actually I shouldn't say the AHA, the American College of Cardiology has actually changed the old ideas of new left bundles is no longer an automatic STEMI equivalent. They've actually developed a flow chart for it now. And you can see the flow chart in there. I'm not going to go through it, but it's basically just takes you through like hemodynamic, the stability of the patient versus findings on the EKG. And it's basically telling you kind of what to do. We can do some of it in the field, but obviously we can't do serial biomarker testing in the field. We can't get troponin levels and stuff. So we can only do part of this in the field. So let's talk about its brother, right bundle branch. This is a block on the right side. Typically, the right side of the heart is a lot smaller, so we don't see as massive of a widening of the QRS. But we typically see a positive deflection. We see QRS durations greater than 120, so it's still wide, but it's kind of shaped a little different with the width. We have this RSR prime pattern, so you have an R, S, and then an R. And you have V1 through 3. You have M-shaped QRS complexes or W-shaped. Sometimes you'll see fireman hat-shaped things they'll be described as. And then when you look at the lateral leads, 1, AVL, 5, and 6, you're going to see a slurred S wave. So if you look at the S wave, you can see that the S wave is slurred. It's not perfectly straight. So those are the keys to the right bundle. These are some of the causes for a right bundle branch. You can't rule in an MI in the presence of a right bundle without first ruling out these other issues. So you have to prove other underlying causes before you can state that there's an MI happening. So there's hypertrophy, there's PEs, ischemic heart disease, rheumatic heart disease. So all these things have to kind of be ruled out. It's not something we're typically going to do in the field. All right, so let's move on to the last couple things. De Winter's T wave. It's a really interesting one. It is considered an anterior STEMI equivalent, but it can present without ST elevation. It can also present with ST elevation. The key diagnostic feature is going to be this ST depression with a peak T waves in any of the precordial leads. So anything from V1 to V6, you see this ST depression and you see this swooping high T wave. This is the De Winter T wave. This is what they're talking about. So there's a little bit more to the diagnostic criteria for it. You have prominent symmetric T waves. You have upsloping ST segment. You have an absence of ST elevation in precordial leads. You also can have ST segment elevation of 0.5 to 1 millimeter in AVR. You guys haven't heard me talk about AVR at all tonight, have you? AVR is kind of the forgotten lead. Nobody really pays attention to it. But in this case, it's something you have to pay attention to. You can also have a normal STEMI morphology may precede or follow the De Winter pattern. And I have a few examples here for us. So you can see the slight depression, the upsloping, upsloping T wave here in all these precordial leads, especially over here in like V4, 5, and 6. You can really see that depression. So you can see that the peak T waves doesn't necessarily have to be super high. It just has to be peaked. Like that's peaked, symmetrical and peaked. And on this, you can see it on this one. You can see it more over here. It's high and peak here, but in V2, V3, it's not like super high. It's only about, 15 millimeters high, but it still would be considered a peak T wave. But you can, no, it's not this one. It's the next one. Aha, here we go. So here's one where you can actually see, you can see the STEMI morphology. You can start to see it in AVL, V2, V1. You can start to see the elevation here, but you can also see that you still have the De Winter T waves here. This would be consideration of, this would be an MI. You would want to take this person direct to a cath lab for cath. It's pretty rare. De Winter's T wave is about a little less than 2% of MIs will have this. So it's a pretty rare, pretty low on the totem pole that you're going to see it. But I guarantee if you pick up a patient and you can identify De Winter's T waves and get a patient to UVM, I guarantee a cardiologist will probably kiss you.
Billy actually had a call like this.
Billy did, yes.
And now I think it was up in J.
Yeah.
I wish I had the EKG, but yeah, he had one.
Yeah.
He actually recognized it in the field, which was awesome.
Yeah, it's a pretty rare finding. Like I said, less than 2% of MIs will show this pattern. So we're gonna move on. I think this is the last one. I think I put in here. There might be one other one, but Wellen syndrome. Wellen syndrome is actually a pattern of deeply inverted or biphasic T waves in V2 and 3. It's highly specific for critical stenosis of the LAD. However, the interesting part of Wellen syndrome is you have these ST changes in V2, V3, but the patient's going to be pain-free. They're not going to have chest pain. They're probably going to be, for the most part, probably complaining of maybe something else. They might have called for a different reason. You also might have normal or minimal elevated cardiac enzymes, but these patients are at very high risk for extensive anterior wall MI within like the next few days to weeks. Like it's going to happen if they have these findings. So on the right side, you can see the diagnostic criteria deeply, and we're going to look. I got EKGs, so we'll look at the actual things. So deeply inverted or biphasic T wave. So biphasic just means that it's both negative and positive. It starts negative, goes above the isoelectric line and comes back down, or vice versa, starts positive, goes negative. You're going to have those in V2 and V3, but it can extend to V1 through 6. You're going to have isoelectric or minimal ST elevation, probably less than a millimeter. You're not going to have Q waves. Q waves are the first downward negative deflected wave in a QRS complex. Sorry, I guess I should have covered some of that. I guess I didn't cover all that stuff as thoroughly as I should have earlier. They're going to have a recent history of angina. So maybe a week ago, they were in the hospital for some chest pain, but everything was negative, so they were sent home. So that would be a marker that you would want to mark in your head. You're going to have you're going to have the following EKG pattern in a pain-free state. So, and then obviously we said normal or slightly elevated cardiac monitor. So maybe a slightly elevated troponin. So this is Wellen syndrome. It comes down to two types, type A, type B. Type A is your biphasic T waves. And you can see that it kind of starts positive, dips negative, and then comes back up. So this would be biphasic, and same with this one. Okay. And then type B is your inverted T waves, like complete inversion of the T waves. This one is 25%. Type A, 25% of the cases will show with type A. However, type A produces type B. Typically, 75% of cases out there will present with a type B T wave. You will have this deep inverted T wave. So, little progression of the T wave changes that you're going to get. You could get a sudden occlusion of the LAD. It's going to cause maybe a transient anterior STEMI. They're going to have chest pain. They're going to have diaphoresis, but it's going to be one of those things that's not going to be captured. Like I said, the patient probably was in the ER for chest pain, but nothing was found. They reperfused the LAD due to, spontaneous clot lysis or even pre-hospital aspirin. Like we could actually fix this problem. Well, at least initially. Chest pain resolves, ST elevation improves, T waves become biphasic or inverted, and the T wave morphology is going to be identical to a patient who reperfuses after a successful PCI. That's another key, is like it's kind of like you reperfuse them, so it would make sense that would happen. If the artery remains open, the T wave is actually going to evolve over time. It's going to go to that biphasic to deeply inverted. And then the coronary perfusion is unstable, however, because there's been damage to that LAD. It's been occluded, it's been unoccluded. So the LAD can reocclude at any time. If this happens, the first sign on the EKG is going to be an apparent normalization of your T waves. It's going to be called pseudo-normalization, because then the T waves switch from biphasic inverted to upright and prominent. And this is going to be a sign of a hyperacute STEMI in this case. I know we're throwing a lot at you with this stuff, but these patients are going to need to go to the cath lab. They're going to be at a very high risk of dying. It's the sudden, like once they progress back to chest pain and evolving chest pain and these ST changes, they start having pain after this, they're going to be at a high risk for cardiac arrest. So they need to get to they need to get down to a piece of cath lab. So real quick, we're just going to talk about VTAC and SVT with aberrancy. So SVT with an aberrancy is basically just an SVT that's a wide complex. It can be seen with both Parkinson-White syndrome. It can be seen with patients that have right bundle branches or left bundle branch morphologies. I just want to bring up the whole point, like VTAC is a very hard thing to rule out in the field. Like cardiologists, like you can see some of the things that need to be some of the criteria that have to be either proven positive or negative to declare something VTAC or SVT. It's a very complicated system. Cardiologists have to use like electrophysiology studies. They run through all these criteria to try to rule out VTAC. For us in the field as medics, as soon-to-be medics, I know that some of you guys are, and our future medics, those that decide to go to school, VTAC versus SVT with aberrancy doesn't change our treatment of these patients. It's not going to. Wide complex tachycardia is wide complex tachycardia. I put our protocols up here for you to see. You guys can obviously refer to them on your own time and read about them. But wide complex tachycardia here, it has adenosine in there. So if you really are, if you're that cardiology guru like I know Stryker is, like, and you really are looking at this thing, you're like, no, I think this is SVT with an aberrancy. Like the protocol allows you to try that. Give the 6 and 12 of adenosine. See if it converts them. If it does, great, awesome on you. Like that's awesome that you guys can do that. Is it going to make a difference though? Are you wrong to just cardiovert the patient thinking, you know what, it's wide, it's fast, it's VTAC? They're stable, give them amiodarone. They're unstable, light them up.
Yep.
It doesn't change the fact. Now, should you know your criteria for ruling out VTAC versus SVT with an aberrancy or AFib with aberrancy? Yes, I think you should, and you'll learn about it in school when you go through school. But in the overall scheme of things, my personal opinion, I know Garrett, I know Stryker's different. I'm sure Clem's different. Talk to Billy. Billy's probably a little different. It's not going to change your treatment. Wide complex tachycardia is a wide complex tachycardia. Treat it as such. If they're unstable, give them the jangles. Give them a synchronized cardioversion. If they're stable and you feel it's SVT with an aberrancy, try adenosine. If it doesn't work, well, guess what? You move on to amiodarone.
It's ventricular in origin, not
yeah, exactly. So
another thing they were finding that people with a previous cardiac history, if they find them in a wide complex tachycardia, 80% of the time it's usually favorable VTAC, not SVT with aberrant conduction.
Yeah.
So you're going to treat them for VTAC anyway, unless you can really pick it up and.
But yeah, so yeah, any questions? Questions and answers. Well, maybe.
If you don't have any questions, you didn't listen.
Please hit us with questions. That's what we're here for. We pretty much hit just under 2 hours on this. I actually got through that a little quicker than I think I really wanted to. But I know myself, I know Stryker, and I know Garrett too. Like we love cardiology. I think it's one of our. I feel like it's our bread and butter when it comes to being medics. Like there's things that I'm weaker at, but I love cardiology, and I know Stryker does too. So, don't hesitate to ask questions. Don't hesitate to come to us and ask us to teach something to you at the station when we're there. Like we're happy to sit down and show you guys 12 leads and why things look the way they do and what they are. We're all happy to do that. So with that, like any questions from anybody?
No.
Well, you guys are easy to please. All right, guys. With that, then we're just going to end the training, and this did get recorded, so we'll work on maybe editing this down and my rambling down a little bit, and we'll see maybe we can get it on CenterLearn for those that didn't or may want to come back to look at things. So thanks for all for coming. See you all next time.
Yeet.
Thank you, Joe and Steve.
Thank you.
Thanks,
John.
guys.
Thank you.
Bye.